I start?
Yes, please, sir. Please go ahead.
A very, very good evening to all of you, and good morning and good afternoon to all the people who are joining from the rest of the world. Today, our guest speaker for the day is our own president of Mumbai Hematology Group, Professor M.B. Agarwal sir from Mumbai. He is going to lecture us on Brentuximab Vedotin based therapy of Hodgkin's lymphoma. This webinar is brought to you by Mumbai Hematology Group, supported by Takeda and Nirvin Life Sciences, and very well managed by Perfect Square. I thank Dr. Avi Sharma and team Takeda, Mr. Paresh Prabhugaonkar and team Nirvin, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Professor Dr. M.B. Agarwal, hematologist from Mumbai. All our discussions were themselves eminent hematologists and medical oncologists, and you participants for sparing those Saturday evening, morning, and afternoon. Tomorrow, that is Sunday, 28th May 2023, at Indian Standard Time 11:30 a.m. and Melbourne time 4 p.m., we have a lecture on ultra high-risk myeloma by Professor Dr. Amit Khote from Melbourne, Victoria, Australia. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Aditya Jandial from PGI Chandigarh, Dr. N. Aditya Mulli from Aster CMI Hospital, Bengaluru, Dr. Asif Iqbal from Dr. Bhuvneshwar Barua Cancer Institute, Guwahati, Assam, Dr. Avriti Baveja from Himalayan Institute of Medical Sciences, HIMSS, Dehradun, Dr. Chepsi C. Philip from Believers Church Medical College Hospital, Tiruvalla, Kerala, Dr. Intizar Mehdi from SCG Hospital, Bengaluru, Dr. Kishore Kumar from Mayot International Hospitals, Chennai, Dr. Leo Prince Mathan from Rela Institute, Chennai, Dr. Mahadev Swami from Manipal Hospital, Goa, Dr. Mallikarjun Kalashetty from Manipal Hospital, Bengaluru, Dr. Nikhil Krishna Haridas from Amrita Institute of Medical Sciences, Kochi, Dr. Satish Kumar from Yeshwantpur, Bengaluru, and Dr. Stelin Bala Chaudhary from Nizam's Institute of Medical Sciences, Hyderabad. Now it's a time to introduce our guest speaker for the day, no other than our president of Mumbai Hematology Group, Professor M.B. Agarwal from Mumbai, who is a very, very famous and renowned hematologist, not only in India, but in the entire world. He's a man of the show for bringing out such beautiful education activities with wonderful topics every weekend since last 3 years from the COVID era. Not only these webinars, but also numerous CMEs and conferences, which has benefited to numerous hematologists of the country, medical oncologists, hematopathologists, and above all, the students and the residents have benefited the most. And most of these webinars are practice changing for almost all of us. No doubt, sir, you have been awarded as a presidential award by the Economic Times of India. Lastly, I thank you from the bottom of my heart for giving me this opportunity for anchoring these multiple webinars, CMEs, and conferences. Not only helped me in knowledging and boosting up my knowledge, but also it helped me to become the anchoring master. Well, thank you so much for being with us. It's my formal duty to introduce you for this webinar again. Dr. M.B. Agarwal is Professor and Head, Department of Hematology from Bombay Hospital Institute of Medical Sciences, Mumbai. He is also the consultant hematologist at PD Hinduja, Lilavati, and Bridge Candy Hospital, Mumbai. He's going to lecture us today on Brentuximab Vedotin based therapy of Hodgkin's lymphoma. Well, thank you. Over to you, Professor Dr. M.B. Agarwal, sir.
Thank you, Amit, for those kind words. We are talking today about Brentuximab based therapy for Hodgkin lymphoma. First of all, I'm indeed grateful to Takeda, who have been instrumental in bringing this molecule to India. And I understand that within the next 3 weeks, you and me will have an access to this molecule officially, though we have been using it unofficially for the last couple of years. Hodgkin lymphoma a term that we learned in our undergraduate days. It's a highly curable cancer. In early stages, the combined modality treatment as shown in the upper part of this curve, and in the advanced stages by chemotherapy alone, almost about 70 to 90% of patients are cured. If you look at all the lymphomas, Hodgkin lymphoma has the best cure rates, to be followed by follicular lymphoma, where survival is long, if not cure. And then you have DLBCL around 60%. You have Burkitt's lymphoma in adult at around 45%. And the worst being the peripheral T-cell lymphomas. Despite these kind of cure rates, there are problems. And these three curves tell you the problem. The first is the red one, which of course we just mentioned that there are patients of Hodgkin disease who are not cured. This is a very modest figure of 10% shown over here. I would say in the real world, it is somewhere closer to 25 to 30%. This is a problem in the beginning. Majority of the patients who relapse in the first 5 years, and after that the curve is flat. The other two curves probably go unnoticed if you are not a sincere student of Hodgkin lymphoma. The one with the blue talks about second malignant condition, and the one in the yellow talks about the cardiovascular event. It's not just that these two events occur. The more glaring is that the curve keeps going up and up and up, whether it is 10 years or 20 years or 30 years. As we know that Hodgkin disease is a disease of young people. Although it has a bimodal age of presentation, but if we skip those elderly people, majority of the people are young. So if somebody who is got this disease at the age of 15 to 25, and if 1/3 of them or even more of them are going to develop a second primary malignancy or going to get a fatal cardiovascular event, and both of these being treatment related, then we understand that there is a huge unmet need in the treatment of Hodgkin lymphoma. And that's what we're going to discuss today. Of care for advanced stage adult classical Hodgkin lymphoma, newly diagnosed. The Germans did their research, came up with a very aggressive protocol, VIACOP and escalated VIACOP, both producing a bit of higher remission rates and probably even higher cure rates, but at a tremendous cost of morbidity and mortality, which was treatment related, as a result of which the protocol never became popular anywhere in the world, including US, Australia. Forget the developing world. Syndrome and a significant risk of infertility. A long line ABVD from Stanford came Stanford 5, which was a condensed treatment of 3 months duration. That was its beauty, but it involved radiotherapy, which is probably not a preferred treatment for advanced stage adult CLL at the moment. And once again, it never became popular outside Stanford. And even probably Stanford does not use it anymore. And then comes almost after 40 years after the ABVD, this blockbuster. BV, that is bendamustine, vedotin, with AVD, that is adriamycin, vinblastine, and dacarbazine. And our focus for today's talk is around this protocol. Brentuximab Vedotin is an ADC. ADC stands for antibody drug conjugate. Now, what you see on the right half of this slide is the structure of the ADC, where in the center you have the antibody. You have a green linker, which links the antibody to the drug. And in the red, you see the drug. So you've got antibody, linker, and the drug. This antibody is the anti-CD30 antibody, which is universally expressed in the classical Hodgkin lymphoma cell. It's also expressed in some other malignancies, especially the peripheral T-cell lymphomas, but that's not the subject of discussion today. Once it attaches itself to the surface of the cell that is positive for the CD30 antigen, it internalizes. Once it is internalized, the lysosomes sort of kill the linker, as a result of which the drug MMAE is released. And this MMAE is a poison to the microtubule. It kills that, which results in the apoptosis of the cell. When this cell dies, the drug is released outside, and as a bystander, it also damages other Hodgkin cells which are lying nearby. So that's the mechanism of action of an ADC. And this was probably the first ADC to get recognized world over and becomes like the mother ADC for all other ADCs to develop. Unlike rituximab, which is a monoclonal antibody, it has not been easy to develop an ADC, and that's the result why you do not have a generic ADC even till today in this country. So, in classical Hodgkin lymphoma, what are the indications of using brentuximab-based therapy? We have to go back by about 12 years. This was in 2011, when the first FDA-approved new treatment for Hodgkin lymphoma came. Remember, the ABVD was 1977. And this was use of brentuximab-based therapy in relapse refractory Hodgkin lymphoma after 2 lines of therapy. And most commonly, those 2 lines will be ABVD as the first line and the autologous transplant-based therapy as the second. Couple of years later, 2015, this drug got its approval as a consolidation therapy after the transplant in a specific group of Hodgkin lymphoma patients who were considered or defined as high risk of relapse after the transplant. So if the transplant has failed, you had BV-based therapy as the 3rd line of therapy. And here, it's not the 3rd line exactly, but it's the consolidation therapy after the 2nd line, that is transplant, basically to decrease the recurrence of the disease or the relapse of the disease, because a subgroup of these patients were considered high risk. And we will define that very soon. And then another 3 years later, 5 years earlier, came the use of or the approval of this compound in the upfront setting as the first line, as a replacement for ABVD, where B, bleomycin, which is toxic to the lung, is replaced with BV. And that's not the only advantage of BV replacing the bleomycin. We'll discuss various other advantages why BV-AVD combination is considered so high in the treatment of Hodgkin lymphoma. So this became the first US FDA-approved frontline therapy for classical Hodgkin lymphoma in adults advanced stage. A few words about the pediatric Hodgkin lymphoma, because just 6 months ago, that is in November 2022, US FDA granted approval to Brentuximab Vedotin in combination with chemotherapy in pediatric classical Hodgkin lymphoma above the age of 2 years, as the first line therapy that is untreated and once again high risk, that is stage 3-4. The chemotherapy protocol which got approval is something like CHOE, same drugs, doxorubicin, vincristine, etoposide, prednisolone, cyclophosphamide, but has been nicknamed in pediatric group as A-WEB. This is the first pediatric approval for Brentuximab Vedotin, and till date it is the only approval. However, once the drug gets licensed, there are off-label uses of compound, and Brentuximab is not away from that. So these are off-label uses which you and me probably have used it and will be using it continuously. The first, which is the most popular off-label use of BV in adult practice, is to prepare a patient for the transplant. So when a patient has relapsed and you are using some kind of chemotherapy protocol to achieve remission, not only achieve remission, PET negativity, so that the transplant can have the highest success. This drug has made a big dent into those chemotherapy-based protocol, and we will discuss that. So this drug is used as a bridge to transplant. Elderly group of patients with Hodgkin lymphoma are difficult patients to treat. And when they have advanced stage disease, the tolerance to treatment has been difficult. It's not easy for you and me to give ABVD that easily to a 60, 70 or a 80-year-old Hodgkin lymphoma patient, as was possible for a 25-year-old young man. And comes the role of, again, BV, Brentuximab-based therapy. It can be used as monotherapy, and even better, it can be used in combination with some kind of chemotherapy. The one which I use most popularly is the Brentuximab Vedotin, and knocking the door is probably Brentuximab with nivolumab, totally a chemo-free regimen. So these two are probably very, very important adult indications, though not US FDA approved, but used in practice very commonly. Exactly same thing for the pediatricians. This compound can be used in combination with some kind of chemotherapy in relapse setting to induce the remission prior to the transplant. And once again, it can be used as consolidation or maintenance therapy after the transplant. My rest of the talk will be divided in various parts, and begin with my first part. And this is Brentuximab Vedotin, frontline advanced stage Hodgkin lymphoma, that is stage 3-4, newly diagnosed Hodgkin lymphoma, BV-based therapy. So we will discuss the Echelon 1 study, which is the sheet anchor of the approval of this particular protocol. Newly diagnosed classical Hodgkin lymphoma is stage 3-4 in combination with AVD, that is adriamycin, vinblastine, and dacarbazine. That's the design of the study. It's a massive study. 1,334 patients, 218 sites, 21 countries, 6 continents. 1:1 randomization between AVD versus ABVD. 6 cycles. Brentuximab used in the dose of 1.2 milligram per kg here, not 1.8, because it is every 15 days. Patients were followed up, PET scans were done. The primary endpoint was to look at the modified progression-free survival, and there were a number of secondary endpoints and number of long-term follow-up, which we will be seeing. And that's the outcome. The upper curve is for the Brentuximab and the lower is for the ABVD. The 2-year modified progression-free survival with Brentuximab was 82% versus ABVD, which was 77%. And this was statistically highly significant. This 23% reduction in the modified PFS with Brentuximab versus ABVD. And this was statistically highly significant difference. So that's the first advantage. When you use BV, you have a progression-free survival, which is longer. Now we have 6-year follow-up data available, and the same kind of finding persists. What you see over here is 32% reduction in the risk of disease progression or death. Now what you see on the right side is something very new, and that is improvement in the overall survival. Hodgkin disease is a disease, or a Hodgkin lymphoma is a lymphoma where you have salvage therapies available as second line, third line, and so on. Despite that, you have here an overall survival advantage of 41% reduction in the risk of death. So that's what is shown over here. Estimated 6-year overall survival rate of 93.9% with Brentuximab versus 89.4% with ABVD. Having seen the advantages in the form of progression-free survival and overall survival, are there any adverse effects? So if you look at monoclonals of various types, and if you look at uncommon, common, and very common side effects, and if you look at when they are used as monotherapy in yellow and in combination with chemotherapy in red, rituximab is here at the top, while brentuximab is at the bottom. That means the adverse effects of brentuximab, either as monotherapy or in combination, are the least. And those which occur are the common ones, rare ones are rare. The two adverse effects that one would like to discuss, and one has to be very aware of it to prevent these complications, is one, peripheral neuropathy, and the second is febrile neutropenia. So talking about peripheral neuropathy, it's a parcel of brentuximab-based therapy. It occurred in higher percentage of patients in the brentuximab arm than the ABVD arm, 67% versus 43% in the ABVD. However, by the end of 5 years, most of the peripheral neuropathy resolved, with only 19% in the brentuximab and 9% in the ABVD group having ongoing peripheral neuropathy. So recovery occurred from 67% to 19% and 43% to 9%. Also importantly, most of the peripheral neuropathy was grade 1 and 2 only, so not incapacitated. So these are the guidelines. No neuropathy to grade 1, for which you need no action, grade 2, 3, where you delay the dose from 15 days to 21 days, or modify the dose, where you drop the dose from 1.2 milligram to 1 milligram per kg. And grade 4, where you stop brentuximab. So you've got patient, you've got a nurse who does the early detection, you've got a treating physician who does the close monitoring. It takes the help of neurologists for the dose adjustment, and you may require other specialties for the supportive care. Febrile neutropenia. So, Echelon-1 study showed that you require G-CSF as a primary prophylaxis in all the patients when you are giving brentuximab-based therapy. This is because there was significant incidence of any neutropenia, grade 3 or more neutropenia, febrile neutropenia, or infections. And the use of G-CSF significantly reduced this from 73% to 35%, any neutropenia, 70 to 29 grade 3 neutropenia, 21 to 11 febrile neutropenia, and so on. There was no neutropenia-associated death in any patient who received G-CSF prophylaxis. So two things when you're using brentuximab for patient of Hodgkin lymphoma, use G-CSF upfront in the prophylactic basis with each cycle, and be conscious of peripheral neuropathy and pick it up on stage 1 and 2. We just started our talk that Hodgkin disease with a standard treatment is notoriously known to produce second primary malignancies decades later, second and third and fourth decades after the initial diagnosis. And we also talked about the BACOP and escalated BACOP creating infertility, and people who are as old as me have also lived with protocols like CMOP, where infertility was common because of procarbazine. So when you look at brentuximab-based therapy, it had fewer second primary malignancies as against ABVD. So that's fascinating. And there were greater number of pregnancy in the brentuximab arm, suggesting that there is no risk of infertility, at least not higher than the ABVD. So this shows you that there was a reduced need for the subsequent anti-cancer therapy, analysis done at 2 years and 6 years, whether it was radiation, chemotherapy, transplant, immunotherapy, or chemoradiotherapy. In the shaded light color, you have the brentuximab based, and in the dark color, you have the ABVD. And overall, at 2 years as well as 6 years, all these were less with the Brentuximab based arm. So the risk of second primary malignancy is less than in the ABVD. We'll now move on to the subgroup analysis, and two subgroup analysis we'll see all the elderly individuals, and the second one is the high-risk Hodgkin lymphoma. So subgroup analysis of echelon 1 assess the efficacy and safety in older people above the age of 60, a group which otherwise does poorly. The modified PFS at 24 months was similar in the two arms. So echelon 1 study tells you that the Brentuximab based therapy is not inferior to ABVD in elderly group of people. 5-year follow-up analysis revealed numerical improvement in progression-free survival favoring Brentuximab in the group above the age of 60. And as was mentioned earlier, this is the group of patients who have the highest incidence of pulmonary toxicity with bleomycin. So obviously, the AAVD led to the lower incidence of pulmonary-related toxicity as compared to ABVD. So elderly individual could tolerate Brentuximab easily, and there was less pulmonary toxicity, and the pulmonary function, the progression-free survival by the end of 5 years was numerically better. Coming to the high-risk Hodgkin lymphoma, patients who had stage 4 disease, excluding the stage 3, and who had IPS score of 4 and 5, 4 to 7. Now, these patients benefited from AVD, that is Brentuximab-based protocol, and the median follow-up of 3 years. You see that the p-values are significant, the hazard ratio here, and once again in the IPS 4 to 7, the p-value and the hazard ratio there. So patients with high-risk group benefited from this protocol, and there was no increase in the incidence or severity of adverse events. In other words, both for elderly, for the high-risk Hodgkin, that is stage 4, and IPS 4 to 7, this protocol becomes a preferable protocol. So that's the summary of the advantage of echelon 1 study, that is Brentuximab-based upfront treatment for newly diagnosed advanced Hodgkin lymphoma. We have 6-year data showing you overall survival advantage, 41% decrease in the risk of death, and manageable safety profile. This represents the first regimen to improve the overall survival as against ABVD on direct comparison. This is despite wide availability and use of active salvage therapies, including even use of Brentuximab later on, telling you that the Brentuximab upfront is superior to using Brentuximab later. And the advantages of fewer second malignancies and no increased risk of infertility. We'll now talk about Brentuximab in combination with other chemotherapy other than the AVD. So it has been evaluated. For example, Brentuximab was combined with ECAPP, which is sort of a protocol of Beacom, and ECADD, once again closer to the Beacom, with 3-year progression-free survival of 90% with virtually both the protocols. Also, Brentuximab ECADD had a more favorable toxicity profile than the escalated Beacom. Now, in elderly and unfit classical Hodgkin lymphoma, there is this UK study called Gravity study. These are difficult patients to treat, and first-line therapy of there who are totally unsuitable for chemotherapy, either due to age or frailty or comorbidity, was the inclusion criteria in this study. So previously untreated patients who didn't have the option of conventional chemotherapy due to age frailty or comorbidities, Brentuximab monotherapy was tolerable, but the activity was limited, and hence combination was preferred. And as I mentioned, my preferred combination at the moment is Brentuximab with dacarbazine, and maybe tomorrow it will be Brentuximab with nivolumab. This is an X-ray chest of a classical Hodgkin lymphoma patient in an unfit subject. CT scan of the same patient, PET scan of the same patient, and this is the PET scan after BV monotherapy. This is another subject, extensive disease, and this is PET scan after BV monotherapy. We'll just see certain individualized therapy using BV. The Brokel man from Germany is a master of this, and he's going to be our guest speaker for one of the forthcoming webinar on individualized treatment of Hodgkin lymphoma, balancing the risk and benefit. He is, of course, the first author of this last year article from where we picked him up as the speaker. Sometimes you have patients of Hodgkin lymphoma who present to you with liver dysfunction, and the liver dysfunction can be very severe. And this is a publication that Brentuximab Vedotin monotherapy resulted in patients of this type into normalization of liver function and control of the disease. This is another case of intrahepatic cholestasis in Hodgkin lymphoma, and once again, Brentuximab coming to a rescue. There's some histology slides. Liver biopsy showing cholestasis, sinusoidal dilatation, and the bile ducts. And this is the treatment. Dexamethasone being given as the first line therapy to see what happens. When it was stopped, the problem recurred. Dexamethasone was reintroduced. And after that, when the BV was introduced, this is day 1, this is day 5, this is day 9, the liver totally settled, and one could introduce the ABVD full cycle. This is Hodgkin lymphoma receiving hemodialysis treated with Brentuximab after the dialysis as a monotherapy. And this is complete remission in a patient of Hodgkin lymphoma in a pediatric patient with TTN gene mutation treated with Brentuximab with chemotherapy without anthracycline, because this gene mutation leads to cardiomyopathy. And this patient's cardiomyopathy improved, the LVEF improved after treating with BV-based therapy. Leaving the adults, now coming to the pediatrics. So BV with pediatric classical Hodgkin lymphoma, upfront advanced disease. Classically, childhood classical Hodgkin lymphoma advanced disease is treated with one of the various protocols which are put up over here. Your OEPA, your ABV-EPC, your OPA, COPDEC. Now, Brentuximab has been used as a replacement of vincristine in this particular protocol. It has been used in combination with AVD like adults, and it has been used as a replacement for vincristine with AV-EPC, and that led to the US FDA approval last year. Cayley, which is a big name in pediatric hemato-oncology. This is a publication in New England Journal, BV-based chemotherapy protocol in pediatric high-risk Hodgkin lymphoma. And these are the results. BV with chemotherapy, event-free survival superior to standard care, whatever was the chemotherapy used. And there was a whole bunch of them which I just showed you. And this is relapse rate with Brentuximab-based protocol, much less than the standard of care. Overall, at end of 3 years, if you look at the EFS, BV led to 97% versus historical control of 81%, and overall survival of 99% versus 97%. This is use of residual node radiation following a BV-based protocol in pediatric practice. And the results are 3-year event-free survival and overall survival in the range of 97 to 98%. And that's what led to approval by US FDA of BV with AV-EPC in November 2022. And this is the first pediatric approval for BV. Is there any study of BV in early? All this what we talked about was the advanced stage classical Hodgkin lymphoma. Are there studies about the early stage diseases? As we know, early stage is either favorable or unfavorable. So if you look at the favorable, so this is Brentuximab based therapy for non-bulky limited stage classical lymphoma. Most of those patients can be cured with standard therapy, but when you are giving combination therapy, the risk of radiotherapy complications which occur late, including cancer, as we just saw in the beginning of my talk, jeopardizes your long survival. Remember, this is a disease of young people. So even if this happens after 20, 30 years, you may still be in 50s and 60s. Similarly, in the unfavorable early stage classical Hodgkin lymphoma, the results were fascinating to the extent of 82% as against control 75%. So to summarize this part of my talk, you will ask me a question. Why should you use BV-based therapy as against ABVD in the classical Hodgkin lymphoma as the first line? So I have so many reasons to tell you. So a superior progression-free survival, more importantly, a superior overall survival. Your acceptable adverse effect profile, you can take care of the peripheral neuropathy by delaying or reducing the dose of Brentuximab by looking for it. And you can take care of neutropenia by giving upfront prophylactic GCS with each cycle. And in the bargain, you have huge reduction in the bleo-related pulmonary toxicity. A very important aspect is lesser risk of second primary malignancy without compromising the reproductive life. It is important for a young Hodgkin lymphoma patient. We also saw subgroup of patients of Hodgkin lymphoma stage 4, an IPS 4 to 7 score, where it is as effective. And we also saw in aged, frail, or unfit patients where it is as effective and tolerable. And lastly, we saw its utility in advanced stage high-risk pediatric patients. I move on to the second part of my talk. And we are now talking about the relapsed refractory Hodgkin lymphoma. And this is even probably more important to you and me, because this is where probably we and all of us are going to use it more liberally than probably upfront. So for most patients of relapsed refractory Hodgkin lymphoma, the available salvage therapy choices are not optimal. The standard treatment is give them high-dose chemotherapy and follow it up with, if they're transplant fit, follow them up with autologous stem cell transplant. So you may have refractory disease, which is probably the worst, or you have relapse disease, in which early relapses are once again worse than the late relapses. And the treatment that you offer to these patients are usually combination chemotherapy, like DHAP, ICE, or any other protocol. They are all same. And today you have an advantage of using Brentuximab-based protocol, which may be combined with bendamustine, which is the standard of care at the moment. And you may use a chemo-free protocol, bendamustine with nivolumab, which may be standard tomorrow. We do not have enough data at the moment. In the relapse setting, if it is localized, you could use radiotherapy. But if it is advanced, again, you were using any kind of combination chemotherapy, DHAP, ICE, plus minus radiotherapy. And today you have the option of Brentuximab with bendamustine, which is my preferred option, which I've used very often. And tomorrow maybe BB with nivolumab. And sometimes you have the option of straight away autologous transplant plus minus radiotherapy. But the standard is giving a combination chemotherapy, which today is challenged by BV with bendamustine. This may be followed by, depending upon the case situation, additional therapy in the form of radiotherapy, salvage chemotherapy, and of course, invariably in a transplant fit patient, autologous transplant plus minus radiotherapy. Now, overall, when you use combination chemotherapy followed by autologous transplant, you have a progression-free survival and overall survival in the range of about 40–50%. So 50% of relapsed refractory Hodgkin lymphoma patients who undergo ASCT do not achieve a long-term remission, by definition more than 5 years. At the same time, all these ICE, DHAP, ESHAP, GVD, they all have their toxicities in the form of bone marrow suppression, infertility, cardiomyopathy, infection, and second malignancy. Unfortunately, in Hodgkin lymphoma, for upfront, we talk about all this, but for the relapse setting, we just accept because there wasn't any option available. So though all this happened left and right, we never bothered to discuss this. So there is a huge unmet need for an effective and safer therapy to treat relapsed refractory Hodgkin lymphoma, to the tune that you may even probably dismiss transplant as a modality of treatment, which at the moment is the standard of care. It is extremely important that the patient who is undergoing transplant achieves CR. And not only achieves CR, he achieves PET negativity. Because the results are so different. If you achieve CR, you are here. A PR, you are here. You've got a stable disease, a progressive disease, you are here. Similarly, if the PET remains positive, you are here. And if the PET becomes negative, you are here. So goal of this bridging to the transplant is to achieve complete remission, which is documented as PET negative. So the use of Brentuximab-based therapy as a bridge to the transplant. Monotherapy or in combination with chemotherapy or chemo-free combinations. So this is a monotherapy study, phase 2, which showed an overall response of 75% and CR of almost 40%. So even as a monotherapy, you can achieve this in 40%. Of course, that 40% is not acceptable by today's standards. So you use BV-based combo. And the standard is BV-based chemo, because at the moment you do not have results of BV-based chemo-free protocols. So you have got BV with Benda, BV with ICE, BV with DHAP, BV with ESHAP, and all that. Variable percentage of patients can achieve PET negativity, and of which BV plus Benda has a PET negativity of 80 to 85%. So that brings me to this particular protocol, that is BV with bendamustine for relapsed refractory patients, international multicenter single arm phase 1-2 trial. And these are the results, the phase 1 and the phase 2. And you can see that the results are similar, and you have change in the tumor size from the baseline of deep degree in large number of patients. This is our own Ranjana Advani as the main author of Brentuximab Vedotin plus bendamustine, a highly active first salvage therapy in relapse setting, published in Blood over here. The protocol is very simple. Brentuximab given on day 1. This is a OPD protocol. Brentuximab given in half an hour. Bendamustine is given on day 1 and day 2. And the protocol is repeated every 21 days. Totally an outdoor protocol. And this is the overall survival. This is progression-free survival of all the patients shown in red and those patients who were followed by transplant in the blue. So transplant does improve the outcome, but the protocol alone, BV with Benda, has significant progression-free survival. Same thing about the duration of complete remission. When you do the transplant, it is better, but overall it is fascinating. So BV with bendamustine is one of the very important and most effective protocol in patients as a bridge to transplant. So outpatient treatment, highly active as the first salvage therapy with CR rate of 73.6%, which exceeds the results by any standard chemotherapy. This is the real world data published by TMC Kolkata. Dr. Mamed Chandi, Reena Nair, and all others are the authors of this paper in Frontiers of Oncology last year. And the results are almost same. The overall survival 75, event-free survival almost 65%. So even in the developing world, you can do this without any inhibitions. This is 3-year outcome of Brentuximab plus bendamustine as the salvage therapy, published in British Journal of Hematology 2020. Overall survival, progression-free survival, and duration of complete remission. And the two curves are for those followed by transplant, not followed by transplant, similar to what I showed you earlier. And this is a response of the entire population. What you see is CR in orange and PR in blue, and the results are to the tune of 70 to 80%. And these are patients who are BV refractory, and still you have some success. BV sensitive, where BV has been used upfront, still you have some success. And BV naive, where the success goes to 80%. So March 16, 2022, after the ASH, Lauren Dembach wrote this, BV with bendamustine is safe and effective even in the pediatric patients in the relapse setting. So far I showed you the data for adults, and this is for the pediatrics. The data on 32 patients in 2 Italian centers. And lastly, though we do not have the outcome of this protocol, but the chemo-free pre-transplant protocol, that is BV in combination with nivolumab, again published by Ranjana Advani and her group in relapse refractory setting, 3-year data. And you will have the curves which are very fascinating. This is percentage of patients who are free from progressive disease. This is percentage of patients free from progressive disease. And this is percentage of patients free from death. And this is by Murray and his group, published this year, nivolumab with brentuximab, with or without bendamustine. So best of both the world. So you've got a checkpoint inhibitor, you've got an ADC, and you've got a chemotherapy. In short, BV-based therapy as a bridge to the transplant is almost the standard of care today, and the preferred chemotherapy is probably bendamustine as of today. I move to the third part of my talk, and this is related to brentuximab-based consolidation therapy after the transplant. So, patients who failed the frontline therapy with ABVD, we saw that only 50% can be salvaged by the conventional therapy of giving them some sort of chemotherapy followed by transplant. That remains the standard of care till brentuximab has come. Long-term outcome of patients who relapse after the first therapy using ASCT is not so good. And same thing applies to the patients who have primary refractory or relapse disease. Now, if you relapse after the failure of autologous transplantation, the outcome is dismal, especially if you relapse within the first year after autologous transplantation, as shown in these curves. So survival following the ASCT failure is extremely poor, with a median survival of just 1.5 to 2.5 years. And patients who relapse within 1 year have extremely poor prognosis of less than 1 year. Now, in these kind of patients, sometimes consolidation radiotherapy has been used. But this has been difficult because of patient or disease characteristics or because of the toxicity of the treatment. They might have received radiation earlier. The disease might be spread to so many sites that radiation is not possible, and the marrow may be so suppressed that you can't give radiation. And toxicity of the radiotherapy, higher incidence of grade 4 and 5 toxicity, again, bone marrow suppression and increased risk of second malignancy. So radiotherapy to be used as a consolidation modality is probably not the best. You can think of allogenic transplant, so auto followed by allo, etc. But one is aware of all the problems associated with allo transplant in this setting, extremely high toxicity. There are various disease-related and patient-related factors which tell you that there is a higher risk of relapse after the transplant. Those patients who have had more than 1 relapses, those patients who had early relapses or who progress after the frontline therapy, those who have extranodal relapses, those are advanced disease and bulky diseases, etc. This is the group of patients who benefited most by giving upfront prophylactic brentuximab consolidation for 1 year following ASCT. Every 3 weeks, total of 16 doses in the dose of 1.8 milligram per kg. This is the Athera study where you are using this as a salvage therapy, BV versus placebo. These are the 3 defining events which define that there is a high risk of relapse. those who were refractory to the frontline treatment, not relapsed, those who relapsed but relapsed within 1 year of the frontline therapy, and those who relapsed after 1 year but relapsed in the extranodal site. All these three groups are groups of patients who have very high risk of problem. And this is the group that is studied in ETHERA, BV versus placebo, as 1 year consolidation therapy after the transplant. And these are the results. There's a 43% reduction in the risk of relapse or progression when you use Brentuximab consolidation. Same thing over here, extended study going right up to 80 months, and you got Brentuximab versus no Brentuximab, and a huge difference between the two, 40%, 60%. Progression-free survival continues to be more pronounced when you use BV. Similarly, an Italian study in the real life showing you the advantage of Brentuximab consolidation after autologous transplant. Overall survival, progression-free survival. The approval after the ETHERA study came in 2015 for Brentuximab Vedotin to be used as consolidation therapy after the transplant. In the green, you see the big jump which occurred in using this in clinical practice. Rarely, though the drug was available from 2012, it was rarely used as maintenance or consolidation therapy. But with approval, the jump came here. And you can see how the jump went on increasing. And you've got a huge green bar where people use this as consolidation. Can you do chemotherapy consolidation as you use chemotherapy bridge to the transplant? Yes, probably yes. There is data here. Brentuximab Vedotin plus nivolumab being used in autologous, but the data is small and for a short period. So we need to see whether this is same as Brentuximab monotherapy or it is superior. This is the data at the moment. And this is showing you after autologous transplant overall survival and progression-free survival. And the other things. In short, consolidating people of Hodgkin lymphoma who are undergoing autologous transplant and who are defined as a higher risk of relapse, either because these were primary refractory cases or because the relapse occurred within 1 year or the relapse occurred after 1 year but at extranodal site. You should use BV consolidation therapy every 3 weeks, 16 doses, 1 year, 1.8 milligram per meter per kg. I'll move on to the fourth part of my talk. Can we dismiss autologous transplant totally in the era of Brentuximab and checkpoint inhibitors? That's the question Alison Moskowitz from Sloan is asking, presented in ASH and the ASH book. Do all patients with primary refractory or first relapse really need autologous stem cell transplant in the era of Brentuximab and checkpoint inhibitors? So it's possible that you can leave out the patients for autologous transplant, and this is a part of clinical study. So high dose therapy with autologous transplant is the standard of care, came up in 1990s. PET adapted strategies developed in 2000. Incorporation of BV and checkpoint is taking place from 2020. And the future probably is to dismiss the autologous transplant, have cure without autologous transplant. And the projected figures are that this may be possible in 60% of patients, changing the total protocol of Hodgkin disease treatment. I come to the fifth part of my talk. What to do when you relapse after the transplant. So you use first-line therapy, ABVD or BV-based therapy. You did the second-line treatment. If they were transplant fit, you had BV as the bridge to the transplant or any other chemotherapy protocol. You consolidated or gave maintenance with BV, etc. The patient relapses now. What do you do to these patients? So that's a difficult question to answer, like difficult to even look at this picture. So can BV be used in patients who relapse after autologous stem cell transplant? The answer is yes, especially if you have not used it upfront, if you have not used it as bridge, and if you have not used it as consolidation. But the answer is also yes, even if you have used it upfront. So this is Brentuximab Vedotin monotherapy for patients who are relapsed or who are refractory after the transplant. So these are the results of monotherapy where objective responses occurred in 75% of patients. And this is monotherapy or a part of chemotherapy where long-term benefits were achieved in the form of 5-year PFS or OS of 31 and 32. So 1/3 of the patients had long-term benefits of progression-free survival or overall survival with BV-based monotherapy or BV-based combination with chemo. Not only that, even after allotransplant, which probably in this country was used and is used today as the third-line therapy for a fit patient having donor, there was some kind of advantage in using BV. So BV can be used after failure of transplant or relapse after transplant. So these are some of the protocols. BV used with certain kind of chemotherapy, which has not been used upfront in second line of therapy. And once again, you have chemo-free doublet. And this is probably going to become most popular third line of therapy, where you'll be using Brentuximab with nivolumab in patients who have relapsed refractory after transplant. And this study showed excellent responses. We just have to wait for the long-term data. So BV with immunotherapeutic agents, both have different mechanism of action. One of them sort of reactivates the T cell, the checkpoint inhibitor, who can handle the Hodgkin Reed-Sternberg cell, and the other one enters the cell and causes microtubular damage. Not only that, BV is also shown to have some kind of immunomodulatory activity. So various kind of results, durable responses. Even triplet has been used where 2 checkpoint inhibitor has been combined with BV. I come to the 6th part of my talk, and this is about doubly refractory Hodgkin lymphoma. Doubly means refractory to chemotherapy and refractory to novel agents. So this is an editorial expanding landscape for relapsed Hodgkin lymphoma, and that is the beautiful cartoon there. You can use cytotoxic agents based on what you have not used. Gemcitabine, platinum, vinca, bendamustine. You can use targeted therapy like mTOR inhibitor, lenalidomide, HDAC inhibitor. And of course, what is most popular in a transplant fit person having a donor allogenic transplant. And future is for CD30 CAR-T, EB virus CTLs, and CD16A, CD30 bikes. And radiotherapy, of course, remains on the card somewhere. 7th part of my talk is, which will be interesting to you, if BV has been used as first line and second line, can it be used in the third line? Or if BV has been used as first line, can it be used as a second line? Or if BV has been used as a bridge to transplant, can it be used as a consolidation? And that's called BV rechallenge. So BV rechallenge in previously BV exposed patients. So despite excellent response rate and acceptable tolerability, most patients will progress on single agent BV therapy. It has been hypothesized that such patients can easily be treated by BV again. So if you use BV monotherapy, you can definitely use second line BV. Phase 2 study, objective response to BV. As a second course, the overall response was 60 and CR rate was 30. Fascinating in people who have seen BV before. Retrospective study of BV in retreated patients with overall response of 53, CR of 17, median survival of 5 months. So retreatment with BV may be an alternative option. 8th part of my talk is the real world data in this kind of setting. So real world data supporting the superiority of BV AVD Echelon 1 trial has been published repeatedly. BV based repeatedly, and effectiveness of post-ASCT BV maintenance in adult children and adolescents have also been published repeatedly. And these are some of the key articles. There are many more, but 7 listed here, where real-world data has matched with the research data. The 9th part is, are there unanswered questions? Most of the unanswered questions are about the combination of BV with checkpoint inhibitors because the data is still unfolding. So what is the potential of BV with checkpoint inhibitor in the relapse setting? How does it compare with BV with chemo or checkpoint inhibitor with chemo? So you've got three different kind of protocols, all are under research. What about the cost effectiveness when you use BV with checkpoint inhibitor versus chemotherapy as the other arm with BV or CPI? What about Brentuximab with AVD versus checkpoint inhibitor with AVD? And what about first line BV with CPI, total chemotherapy protocol in a newly diagnosed patient? They're all questions, no answers. And the last part of my talk is conclusion and future perspective. So this is a slide probably which summarizes everything that I spoke to you just now. So BV-based frontline protocol. Patients who are under the age of 60 and have got advanced stage 3, stage 4 disease, or who have got IPS 4 to 7, consider BV-AVD. So younger people, stage 3, stage 4 disease, IPS 4 to 7, consider BV-AVD as a replacement of AVD. We have discussed everything: progression-free survival, overall survival, freedom from sterility, freedom from second malignancy. If you've got age group above 60, then the sequential BV-AVD, I didn't discuss too much of this, but sequential use of BV-AVD can be extremely non-toxic. In a relapse refractory setting, before the transplant, consider BV monotherapy with 50% CR rate and BV combination with 80% CR rate as a bridge to transplant. So this will be especially in BV naive patients. And the combination that I use and which I strongly emphasize is with bendamustine. Post-transplant, once the patient is in remission, maintenance to be given for 1 year, 16 doses in patients who are high risk and who are BV naive or previously not exposed to BV. Now, this will be important at least for those three groups of patients who are primarily refractory or who relapse within 1 year or who relapsed at extranodal site after. And lastly, when you've got relapse or refractory after the transplant, you can use BV monotherapy or BV combination. This may be especially the only route if the patient is ineligible for checkpoint inhibitors, or as an experimental tool, you can use BV with checkpoint inhibitor. Future perspectives. Last 12 years of experience with BV has clearly demonstrated that CD30 is a highly valuable therapeutic target on almost all patients of classical Hodgkin lymphoma. BV is the pioneer as far as the ADC approach to therapy is concerned. It has now become an established standard of care for classical Hodgkin lymphoma. The long-term data from phase 3, and we have got 6-year data, shows the durability of the benefit. We have now a huge amount of real-world data where the benefits have been translated into the clinical practice. Some questions remain unanswered, especially the novel BV-based combination with checkpoint inhibitors. This is my last slide. What it tells you that you need to talk. You got options. None of the option is totally to be dismissed, and none of the option is universal. So you need to talk to your patient. There are a group of patients who can afford BV-based therapy, and they must never be deprived of the BV-based protocol. And once again, I thank Takeda for bringing this molecule to us. And this webinar is essentially because Takeda is on the verge of launching this by 15th of next month. I stop here. Thank you.
Thank you so much for that fantastic lecture, as always. Always good to hear from you. So as we start with our question and answer session, I request all our discussants to please put the raise hand signs. In the meanwhile, there are some questions from the audience. Dr. Mohammed Basalathullah has asked that can we use PEG GCSF when we are using Brentuximab?
Probably yes. It has not been used, but yes. So as we do in various kind of solid tumors and lymphoma, one dose PEG GCSF 6 mg, day 4, yes, probably yes.
And he also wants to know what is the dose of Brentuximab and the number of cycles when used with BV plus Benda.
1.2 milligram per kg every 15 days. So just you are replacing bleomycin day 1, day 15 with bendamustine. While if it is used as a monotherapy, it is once in 3 weeks, 1.8 milligram. But be careful of peripheral neuropathy. The moment you pick that up, reduce the dose to 1.5, 1.2, or increase the interval.
Thank you, sir. Another question from Dr. Aditya Murli regarding your favorite protocol, BV plus decarbazine. What is the dosage, schedule, and the side effects?
Doses are identical, 1.2 milligram per meter square. Dacarbazine 375 milligram per meter square. Side effects are not really very different. Dacarbazine, as you know, is holy water. You can use it very easily. We are all used to it in ABVD. So there is no different side effect. That is the protocol of my choice, which I've used. So bendamustine with the Brentuximab as a bridge to transplant. And when I have to use it for elderly people, it is Brentuximab with dacarbazine.
Thank you, sir. Dr. Intizar Mehdi, your question, please.
Sir, thank you very much. Fantastic talk as usual, like Dr. Amit mentioned. So you showed in your talk, sir, that FDA has recently approved Brentuximab therapy for high-risk Hodgkin lymphoma in children and young adults, that is below 18. It was just in November 2022. So I also read the paper in your talk and earlier, the Euronet pediatric Hodgkin lymphoma protocol, which uses actually OIPA and COPDAC based chemotherapy. There also they have seen that substituting vincristine with brentuximab in both OIPA as well as the COPDAC has made a huge difference. It has improved the survival further in this high-risk group children and toxicity is also. So would you recommend using Bren upfront for all the high-risk group in children and young adults based on the available data and any experience, sir, in the young adult population from your side, sir?
Absolutely. I think younger the patient, more the need. And now that we've got the approvals, we have become more liberal in using it in the pediatric age group. These are the patients who are going to live for 70, 80 years or 90 years. So that's the group where you want to save them from second malignancy, you want to save them from infertility, you want to save them from relapses. So whatever data is available today, it justifies this in the younger people much more than the elderly people. So I will probably totally go with it.
Thank you, Dr. Intizar.
Okay, sir.
Dr. Asif Iqbal.
Thank you, sir. Thank you. Very much answers my question. Because the only doubt which most of the groups feel is, since the cure rates of Hodgkin lymphoma is excellent with the contemporary protocols, even in pediatric it started with ABVD and now just to limit the toxicity, OIPA, COPDAC, but as you rightly mentioned, the risk of second malignancy and infertility still remains. So I think it's time to shift to at least Brentuximab, at least in the high risk group. I agree, sir. Also, for example, if you have used, say, OIPA, COPDAC based chemotherapy, say you are dealing with a stage 3 or 4 child, and at the time of interim evaluation on the PET, say it's a partial response. So the protocol says that even if there is a good partial response, you can go ahead and continue with COPDAC. But in the current era, since we have approval for a Brentuximab, if you have not used in the high risk group for some reason, if there is a partial response at the interim evaluation, definitely would you recommend, sir, adding Brentuximab therapy at that time instead of insisting in the COPDAC arm if somebody is using that?
Yeah, so yes, Dr. Intizar, there is a sort of paucity of pediatric data in last 5 years. That is what I noticed when I was trying to review the pediatric data when one of our webinar was on pediatric Hodgkin lymphoma, and we had speaker from TMC Kolkata. What I saw that of late, everything from the adult is being sort of translated into the pediatric, whether it is BV, whether it is checkpoint inhibitor, indications, everything is being just sort of transferred from the adult data to this data. And I see that there is a sense in it because as we do in adults, that after 2 cycles of ABVD, one thing which I didn't discuss at all today is the PET-guided de-escalation or escalation of the treatment. So after 2 cycles, today you do that left and right for almost all the patients. So ABVD becomes minus bleomycin if it is good, if the PET becomes negative, or it becomes BACOP if the response has been poor. Same thing applies to pediatric. Why should you not change the protocol immediately if your PET scan has not become negative after 2? Because otherwise you will have a very high risk of relapses in these patients. So I agree with whatever your comment is.
Thank you, sir. Thank you, sir. Thank you very much. Thank you, Dr. Amit, for the opportunity. Thank you.
Thank you. Dr. Asif Iqbal, your question, please.
Yeah, sir, I have an experience of using Brentuximab in a couple of patients. I, however, had one bad experience. I mean, in a patient where, you know, sir, in our patients, actually, we cannot use Brentuximab upfront or immediately after, even in the second line. So the patient used GMOX or GDP meanwhile. And then when we do not have a good response, we start giving bendamustine plus BV. After 6 cycles, the patient has a good response, but not a complete response. So we kept on giving bendamustine and BV, but after 10 cycles, patient started having relapse, cervical lymphadenopathy again. This time around, when we did a biopsy, it came out to be a relapse Hodgkin's lymphoma, but CD30 was markedly underexpressed. So now what to do? I mean, have you ever come across such a situation?
So I haven't used it for more than a year. In fact, when I've used it after transplant also, very often 7 months, 8 months, 9 months, I started facing the problem of peripheral neuropathy, and only the reduction in the dose and delay was also not adequate. So very often I just stopped there at 7, 8, 9 cycles. Bendamustine is notorious. To be very frank, even in follicular lymphomas and CLL, I don't complete 6 cycles. I stop at 4, 5 cycles because as such, you're not curing and I don't want any complications. So 10 cycles, etc., I haven't used at all. If you're, because of all this, the discussion on allotransplant has taken a backseat. I don't know whether your patient was transplant fit or not, but if there is a patient who is transplant fit, I think in this country, third line of therapy in a cost-effective fashion and long-term outcome, allotransplant remains the standard of care with almost about 30% at least cure. 1/3 of the patient can get cured without any long-term toxicity. Yes, patient is not transplant fit. There is no donor. There are various other reasons. Patient doesn't want transplant. Then with the availability of these 2 agents, maybe your patient couldn't afford probably combination of checkpoint plus Brentuximab. Otherwise, that expensive therapy can be a good therapy in the third line.
No, sir. Actually, my question is that nivolumab is indicated for post-transplant, so we can use it upfront. I mean, before transplant in this, or I mean, those changes can be done, right?
Yeah, nivolumab has been now tried everywhere. Exactly what I spoke of Brentuximab, it is being tried everywhere. Sure.
Okay. Sir, if I have like anybody from Takeda, like this cost of Brentuximab is very high. So any idea, like, sir, what cost it will be available when?
I asked them this question. So they said this will be much lower than what you are spending just now. At the moment, you and me are getting 50 mg. At the
1.3 lakh.
Yeah, well, approximately 1.25, 1.3 lakhs. So that is the cost at which the drug is being imported plus the commission of the importing agency. Now this will be officially launched. So the cost is going to be less. But till they launch it, they don't know the cost. So 15th of June, maybe we will know the cost. But one thing is for sure, it will be less than that.
Thank you, sir.
And most of the patients will not require more than 2 vials per dose.
Thank you, Dr. Asif. Satish Kumar.
Yeah, thanks, Amit. Thank you, sir, for that lucid presentation. You make the topic look so simple and so easy. So this is an extension of the question Dr. Intazar asked. I was actually asking the same thing. For adults, we all use now PET-based or PET-adapted therapy. So again, due to financial issues, I agree that for at least some subset of patients, we should shift to Brentuximab plus AVD. But if you have started ABVD, and after 2 cycles, if the PET is not showing complete remission, then is there any data looking at after 2 cycles, whether if we shift to Brentuximab plus AVD versus escalated BCOP, because as of now we are giving escalated BCOP, though the number is small and it's a tough cycle. Have they looked into it, and what is your experience in that pet adapted therapy, sir?
Not really. So I would say you should use Brentuximab with AVD again. You should use Brentuximab based protocol, but something else. Because now your goal is that this patient should get into CR as quickly as possible, remain in CR. So probably failure of AVD, you should, you should remove that particular part of it. Can you hear me?
Yes, yes, sir.
You got it. Now you're back.
Oh, sorry. Thank you, sir.
Okay, fine.
Thank you, Dr. Satish. We have got some couple of questions from the audience. Now, Dr. Mohammed has again raised a question that what is your experience regarding BV infusion reactions? And can it be given for 30 minutes for all the patients?
So ultimately, it's an antibody. You have to take care like an antibody. It's an outdoor treatment because it is very safe. It can be given in half an hour. You have to use the prophylaxis. And in literature, I have not seen, but in literature, even anaphylaxis has been reported. So, I mean, you can't take it lightly, just like blood transfusion or rituximab or obinutuzumab or daratumumab, you have to use them in the same package.
Thank you, sir. Dr. Abhishek wants to know that what is the real world data which supports Achillon-1 trial?
Oh, so I had put up some references there. It's clearly shown that the real world data matches the Echelon trial. There are a number of them from number of countries. And they are right data, 3 years plus data.
Thank you, sir. Dr. Mallikarjun, your question, please.
Thank you for the opportunity. Excellent talk, sir, again. So I may have to digress from the topic. I have a patient with me now. So this was regarding Brentuximab. So there is this patient who was treated for advanced stage DLBCL CD20 positive, high risk. So they had given R-CHOP with etoposide. Now she's progressed within 6 months. Now at relapse, she has CD20 negative, CD30 positive, diffuse large B-cell lymphoma. Again, fairly advanced stage. There's a lot of. I was reviewing to see if there is any data of usage of Brentuximab in this situation, sir. So, do you have any such experience?
So there are anecdotal reports published in literature, and we had a patient like this whom we consulted with Dr. Rajina Advani. So she said these are as such bad cases. So when you got a target, why not? So say use Brentuximab definitely. So
Yes, sir.
when you got a target, there's a bad case. They have poor prognosis with compared to the one who are CD30 negative. Experience is small, number of cases small. You will never have large trials or large data on this. So recommendation is you should use it. The last data is only say you got peripheral T-cell lymphoma, systemic and Hodgkin. These 3 diseases. Rest is all is anecdotal case.
Yes. The other thing is, how would you use the checkpoint inhibitors and Brentuximab in the algorithm of therapy? What is the role of checkpoint inhibitors now?
So I don't know that we know the exact role as such. It's a popular regimen. I see people using it even in India when cost is not an issue. I feel that chemotherapy is an important component of cure. So I personally believe that all non-chemotherapeutic protocols will be palliative. So I don't believe in any one of these as monotherapy. I am personally at the moment, I have no data to go by, but I personally don't believe that BV with CPI should be a preferred modality at any stage. It's only if the patient is chemo unfit or you have used most of the important chemo drugs, you're not left with any effective regimen. Then yes, third line you can use both of them.
Thank you, sir. Thank
Whether
you.
that will come into the first line or second line or as a bridge to transplant or as a consolidation is something for some other day. It may come as a bridge to transplant. It may come as consolidation. It will come as first line. I'm not sure.
Thank you, sir. Thank you, Dr. Amit.
Cost will be very prohibitive.
Yes, sir.
For some small gains.
Thank you, Dr. Mallikarjun. Dr. Aditya, your question, please.
Good evening, sir. Fantastic talk, as always. So I have 2 amateur questions for you. So the first thing is like, as a couple of panelists have also asked. So as far as like PET guided therapy in the era of BV AVD is concerned, so do you envision a scenario where, on the basis of interim PET2, can we de-escalate BV and just continue with AVD?
So I had this in the list of my unanswered question. I removed it because I had not discussed PET at all. So I removed
Okay,
it.
sir.
This has not been sorted out. There's no answer to your question.
Fine, sir. And second bit naive question is, so we have 50 milligram vial of Brentuximab Vedotin. In a lower middle income country like India, so instead of using 2 vials, can we have a fixed vial approach, like combining 50 mg with AVD, and instead of going a weight based?
So peripheral neuropathy is directly a dose-related phenomenon. So, I mean, as we are used to that, we take 2 patients and use the vials optimally. That may be the only standard way. If you are coming to a dose of 80, 90, I think that 10 and 20 can be extremely hazardous if you're going to give it, because it will cross 1.8 or 1.2, whatever your challenge is.
Yeah, so yes, sir. So my ask was just capping the dose at 50 mg. Is it possible, because you have a vast experience, sir?
You mean underdosing?
Yeah.
So no data. You are forced to underdose sometime because of peripheral neuropathy is a different issue. Because there you have no option. Because you want to give the drug and the neuropathy is setting in. You don't want it to progress. So all those formulas are there, 1.8 becoming 1.5, 1.2, 1, and interval increasing. All those things are discussed. But in a disease which is so curable, one will be always concerned of capping at 50 if the dose comes to, say, 0.9 per kg or something.
Sir. Thank you, sir.
Thank you, Dr. Aditya. One wonderful question has come from Dr. Saswat Saha. How to differentiate between bendamustine neuropathy versus Wind-twisting neuropathy? And if the patient develops grade 2, grade 3 peripheral neuropathy on A plus AVD, which drugs should be modified and which drug should be omitted?
If the patient is on bendamustine, it is bendamustine.
So how do you differentiate?
Neuropathy has to be looked at very carefully. You have to grade it. And if it is progressive, significant, you have to stop Brentuximab. You cannot continue Brentuximab with significant peripheral neuropathy, even if you feel it was due to some other agent. This is the toxicity of Brentuximab, which is a dose-limiting toxicity.
Thank you, sir. One question from Dr. Nikhil. Is there any specific cutoff of CD30 expression before starting BV therapy?
So this has been, see, in classical Hodgkin lymphoma, it is universal, so there's no discussion. But this has been discussed with the peripheral T-cell lymphoma. And there are people who have said that 1% documentation of CD30 is good enough for me to use it. It may be out of frustration because T-cell, PTCL, you don't have many good outcomes as such. So when you have somebody who's demonstrated some CD30 positivity, you don't want to miss the bus of using Brentuximab. Others have put the figure anywhere between 10 to 30%. So maybe 10% is the realistic, that you should have at least 10% documentation. People have said 1% is enough. People have said that it should be 30%. In Hodgkin, there is no discussion because it's a definition of the Hodgkin cell. If you don't have CD30 positivity, you doubt the diagnosis.
Dr. Amir Sharif wants to know that how I treat a patient who has early failure post-transplant.
I'm sorry, repeat the question.
How to treat a patient who has failed early post-transplant, relapse post-transplant.
Early relapse post-transplant.
Absolutely.
So we just talked about that these are very bad cases. Here you move on to the third line. I will invariably use an agent which has not been used. So in our country, as we were just discussing, allotransplant is a good option for transplant fit, eligible, money no issue, donor is available. Then allotransplant can give you salvage of without any significant problem of at least 30-35%. In Europe, they've talked about 45-50%. So allotransplant, I think, does not disappear in my setting. Otherwise, if you have not exposed the patient to BV and CPI, you can use BV plus CPI, because most of our patients probably will not be exposed to this, but that requires a lot of money. And if money is an issue, and if you have not used one of these, then you can use one of these, which whatever combination chemotherapy you want to use. But third line is a bad line. I would go for allo transplant if patient is fit for transplant.
Thank you,
Amit,
sir.
can
Yeah, please go ahead, Dr. Kishore.
thank you, sir. It was a great lecture. Brainstorming, I should say, quite confused what to ask. Sir, one practical question. You have been again and again mentioning about allo transplant, and somehow we had 3 patients. One is kind of stuck with me right now. 2012, Hodgkin, straightforward, kind of early stage at that time, ABVD 6 cycles went well. 16 relapsed, then we went on with the DAP, 2-3 cycles, if I'm right, kind of PET negative before ASCT, and he went on with a beam autograft. Again in 22, early 22, there was a relapse. It was actually for the post. There was no Brentuximab maintenance which was given. That was in 2016. With 16-17, we did the transplant. Our access was not that great at that time. The cost was also so high, even compared to the cost right now that is available, I suppose. Now left with no, we went on with the BV with Benda. Just 100 for 2 days and 1.8 every 21 days. And after 5 cycles, he kind of after 4 itself, we repeated a PET, just like doing in a regular lymphoma. PET became negative. The only brother, he was a haplo match, but we were kind of forced, since PET was negative, he wanted some more time for a transplant. We went ahead with the 5th dose of BV and then went ahead with an allograft in last November. So haplograft actually. So he has been doing perfectly well. He is on Jakavi right now because of post-transplant GVHT and things like that. Since they saw a response which was kind of very dramatic with Brentuximab, like now from the patient side question to me is about using it again in the maintenance in post-allograft. So I don't think there is any data to say that, but the patient has been behind me. Money is not that great an issue for them. What's your take on this, sir?
So Brentuximab has been used for relapsed patients after allo with some benefits, even in people who have been exposed to Brentuximab earlier. So if this chap is very enthusiastic, and if he has no contraindication, there's no neuropathy, he's got no money problem, this is an anecdotal use of Brentuximab in a post-transplant setting in a person who benefited from the drug to make him fit for the transplant.
Maybe at the lower dose, we don't know. Maybe you mentioned about.
We will never have an answer to this, but I think you have got a genuine case who responded to Brentuximab, who tolerated Brentuximab, he became fit for the allo. Now he's got an allo, and he wants to decrease his chance of relapses. So anecdotal.
Yes.
You have no answer to this question, but makes a sincere case.
Understood. Thank you, sir.
Thank you, Dr. Kishore. Dr. Nikhil wants to know any about role of interim PET in BV treated patients.
So we just had that question discussed. We don't have an answer to that. That remains because that was not a part of echelon trial. So we don't have an answer to that. In practice, you can do it the way you do it for ABVD.
Thank you, sir. And again, a very repeat question from Dr. Thanda about your experience regarding post-transplant BV in high-risk patients and any adverse effects if you combine it with bendamustine post-transplant.
So post-transplant without relapse, probably there is no data of using bendamustine with Brentuximab like that, consolidation. Brentuximab as a monotherapy, there is enough data, and it is useful for that 3 subgroup of patients that were included in ATHRA trial. So if your patient falls in those 3 groups, I would say this is mandatory if there is no contraindication or money permits. And for the rest, probably it will be anecdotal. Combination of bendamustine without relapse will be a question mark. They're exposing the person for something which is not required. I would say that.
Amit, comment with respect to the interim PET. Interim PET, even with respect to all the other trials of downgrading the therapy or leaving aside drugs, was more for toxicity profile. It was overall responses and PFS or OS, whatever you see, it was all similar. That's what we wanted to do ultimately.
Maybe if BV has got an excellent this thing, interim period again becomes very anecdotal. It may be for our own satisfaction, we may be doing it. So I don't think that's going to be. And even the echelon trial was really done. The reports are not out. So initially, when they were recruiting, they didn't had this as a part of their trial protocol itself. So that's the reason they didn't probably include it.
And there are publications when PET negative after 2, when you de-escalated, what are the failure rates? And when you escalated, what are the complications? So all that has been discussed. And some of the data is on biopsies also, that when you got something PET positive and they've gone ahead with the biopsy and published that, how many were false negative? So after, PET2 positive, biopsy negative, so what were you doing? Was okay, not okay? Anyway, that there's no end to that discussion.
Thank you, Dr. Kishore. If anybody has any question for Dr. Agarwal, sir. One question has come from Dr. Saswata Saha. I don't understand that question. What is about while pulling? Is it feasible for BV? I don't know what is while pulling.
Biopulling.
While pulling.
While pulling, I think we just answered that question. If you've got 2 patients at a time and you do 75 for both the patients, then why not? They're both together in your institution under your care. So why not? But underdosing, overdosing, keeping the vial, all that I think is probably non-scientific.
So one more questions are keeping on pouring. Another question, last question from Dr. Kaushik. He wants to know that your opinion on vial preservation, if half a dose is used, and any manufacturer recommendation available regarding duration and temperature conditions.
Answer will be big no.
Perfect. So I finished all the questions from the audiences. Anybody has any question for sir from the discussants? Anybody? Well, sir, so we have finished all the questions.
Thank you.
If no other questions, so thank you so much for the fantastic lecture, fantastic discussion, and thanks for giving me this opportunity to anchor this platform.
It was an opportunity to me to speak to you. I learned a lot while preparing this, and wonderful interaction. Galaxy of eminent hematologists and oncologists have participated. Questions were fantastic, and you anchored it so well. And thanks to Takeda for bringing this molecule, for sponsoring this particular session, and thanks to Kalpesh and his team for managing the show. And again, Amit Khurana, thanks to you.
Thank you, sir.
Bye-bye. Bye. Good night. Bye.
Thank you, sir. Thank you, everyone. Good night.